All right, good afternoon and welcome. I am Jamie Ard. I'm the Chief Science Officer and Director of the Clinical and Translational Science Institute here at Advocate Health in Wake Forest University School of Medicine. And it is my pleasure to welcome you to this Celebrate Research moment on behalf of Dean Ebony Boulware. Clinical research plays a vital role in advancing medicine by translating scientific discovery into treatments that improve patient outcomes. Through clinical trials and patient-centered investigation, researchers evaluate new therapies and develop new approaches to care. During Celebrate Research 2026, we recognize the investigators and research teams whose work is really important in moving these advances forward across our academic learning health system. Few areas illustrate the impact of research more clearly than cancer. Advances in prevention, early detection, and the treatment have dramatically improved survival and quality of life for many patients. Behind every one of those breakthroughs, you'll find a committed researcher, clinician, patients all working together to advance knowledge and improve care. Cancer research saves lives because discovery becomes care. This work reflects our shared commitment to advancing discovery and improving health through our academic learning health system. And now it's my pleasure to introduce Dr. Ruben Mesa. Dr. Mesa is the president for the Advocate Health Cancer National Service Line. Our Cancer National Service Line brings together cancer care, research, and educational programs across the enterprise, covering over 50,000 newly diagnosed cancer patients across 6 states. He's also the Vice Dean for Cancer Programs at the School of Medicine and Executive Director for the NCI designated Atrium Health Wake Forest Baptist Comprehensive Cancer Center. That's a mouthful, Dr. Mesa, but we're glad that you are here to facilitate our conversation today. So I'm going to hand it over to you.
Wonderful. Well, thank you so much, Dr. Ard, for helping pull us together today, as well as all of the organizers for this month of Celebrate Research. A huge shout out to Dean Boulware, Christina Ferdui, Lynn Waganacht, together this entire month of celebrating research across the Wake Forest University School of Medicine, across all of the Advocate Health enterprise. So today we're going to take a deep dive in cancer research and talk about how cancer research is helping to save lives. And for this, we've brought together some wonderful physicians, researchers, scientists across our enterprise to talk about exactly that. But before we do, let's just talk a little bit about the problem. In 2026, we estimate that there will be approximately 2 million individuals that have cancer in the United States, and that there will be approximately 600,000 individuals who will pass away from cancer. This is, for me, the much more problematic number. The individuals whose lives are cut short by cancer and how we really try to change this. There are things we celebrate. 70% of cancer patients diagnosed 1975 through 2021 now are cancer survivors, and we hope for that number to grow. And we'll be talking both about treatment and survivorship today. We know there are cancers that we have made significant progress on, in particular in lung cancer, due to efforts with smoking cessation, as well as advancements in lung cancer treatment. However, there are other cancers, particularly those that can be driven by the metabolic syndrome and obesity, that are increasing, such as uterine cancer. As a cancer team across Advocate Health, we have a tremendous amount to be proud of the impact we have in our communities. One of the largest cancer programs in the United States, over 50,000 cancer registry cases, but last year we have recently learned we saw over 300,000 discrete individuals with cancer and blood diseases across Advocate Health. And with this, we have extensive care across each of our divisions based around 5 magnificent hub cancer centers and many outstanding regional cancer sites. Looked at another way, we are the #1 providers of cancer care for both Wisconsin and North Carolina, caring for about 1/3 in each of those states. #2 for Illinois, and one of the top cancer care providers both for South Carolina and Georgia. Additionally, when compared against the U.S. distribution of cancers, we see that our patients are a fairly accurate reflection of the types of cancers and their social determinants of health across the United States. So as we learn from our efforts at Advocate Health, it can be very reflective of the U.S. population as a whole. Now, our goal as we've come together is one cancer national service line, with research being a central piece of this. And the vision of our broader national service lines in cancer, heart and vascular, and neuroscience is to bring the very best of what we are to wherever our patients are. So not only are we having world-class care and research and access to trials, but that we do so in a way that is most patient-friendly and for patients to experience close to home. We're vowing that together we will cure more patients by decreasing late-stage presentations of cancer, make cancer journeys easier, cutting-edge options from Green Bay to Greensboro, one evidence-driven cutting-edge advocate way, custom-tailored cures for the individual, and democratizing expertise. So with that, let's talk about research. And we've decided to talk about 4 different topics, and each topic will have 2 different speakers from different parts of our enterprise that are having an impact in this area in complementary ways. So first, let's talk about advances in cancer screening. And for this, we both have Dr. Dan Carrizosa, who is both our Assistant Director for Community Outreach and Engagement for our Comprehensive Cancer Center, as well as a lung cancer expert based in Charlotte, and Amy Griffin, who has been a tremendous leader for us in Georgia and has been front and center with novel approaches in mobile breast cancer screening. So first, let's kick it off with Dr. Carrizosa.
Thank you. Well, it's my pleasure to talk a little bit about community outreach and engagement. Why do we do research? Well, we do research to help people, to help our community, to help those we love. And research isn't always there for all our people in our community. We don't always ask people to do research. We don't always have research that means something to them. Well, community outreach and engagement is the heart of our Comprehensive Cancer Center, and we work on this. We are the community, the outreach, and the engagement in research, and we work throughout all aspects of research. Next slide, please. We have 3 different aims in community outreach and engagement. The first, simply put, we actually have to understand the cancer burden, who we're treating, what we're treating, why we're treating it. We need to provide this information to all of those in our cancer center, both the researchers and the providers, and provide this information to our community partners, our community, to make sure that there's this bi-directional communication, that we're talking between and the people we serve. A great example of this is our community advisory board that actually provides a voice to our cancer center, provides a voice to our researchers, provides a voice to our community. Our second aim actually talks about those statistics that we looked at. How do we actually figure out and find the settings and actually the way we actually screen people and create cancer control and prevention? We actually are making sure we need to reduce the cancer burden and actually improve outcomes. And our last aim actually is about research. How can we make sure that our community expertise is involved in our research? How we actually make sure our community gets to research, hears research, sees research, and that any policy we do actually helps our community. Next slide, please. So in discovery, translation, and implementation and normalization, the Office of COE is involved all aspects. We want to make sure that our community expertise is actually provided in all our research, that our researchers are providing things that our community wants to do. Our community will have questions that they want answered beyond what actually our researchers think, and we need to make sure we are involved in that. We also want to make sure that all research actually helps all those we serve. We also, in translation, want to make sure that we provide research availability to everybody. So we provide funding through pilot studies, RFAs, other things to make sure that we can make patients available to research, and that we can also make sure that all our community is represented in research. And ultimately, we want to make sure there's real world context. And finally, with implementation normalization, we want to make sure that our community partners are involved. We want to make sure that our community is involved. We want to increase recruitment, retention, access. We want to make sure that our research team and our communities actually speak, that they hear each other, that they learn from each other, and they grow from each other. This dialogue is important to research and how our cancer center works. Next slide. In that second aim, we talked about how to help with the cancer burden and improve our cancer in our community. We do this through settings of screening, education, and outreach. Each person we screen is actually navigated to make sure that if they have a finding that actually is concerning, that they find a way to get that taken care of, that every member of our community can feel access to screening. You can see all the screenings we've done in this last 5 years, how we've impacted all these people in our community. We've seen in our community that some people can't get access to screening. One example is lung cancer screening. We saw many people in our catchment area that had high burdens of tobacco use that did not get lung cancer screening. So we helped create the first national mobile lung cancer screening unit. And we have 2 of these now that enter into our community and are able to provide this lung cancer screening. All of this also led to research. We have an under 55 screening trial looking at patients that are younger than our national screening guidelines who actually smoke significantly to see if we can provide lung cancer screening to them and provide an access to finding lung cancer earlier. All of these aspects of screening and involving the community and education provide ways for our research to be heard. We also want to be able to make sure that we provide ways for our researchers to actually learn about the community and have these different dialogues to understand what's the best way for us to do our research in the community and actually to be able to be successful. So ultimately, community outreach and engagement is the heart of all we do. It creates research opportunities and makes research available to all. Thank you. Next slide.
Wonderful. So we're going to be taking questions at the end. Please be entering them in the chat, and we'll do this as kind of a group Q&A at the end of the session. So thank you very much, Dan. Next up, Amy Griffin, who will share some of the innovative approaches they've been taking to mammography in Georgia.
Thank you, Dr. Mesa. Excited to share our unique approach to mobile mammography here in Georgia. So in Georgia, our challenge with access to breast cancer screening really is a geography problem, and the geography creates an access issue. So you see 2 circles there on the map of Georgia. The upper left circle represents Northwest Georgia, where Floyd lies, and then down in the middle of the state are our friends at Navicent down in Macon. And we have very similar situations there where the lighter blue counties that kind of surround that core central location have lower screening adherence rates. And so this map is actually based on USPSTF guidelines, which again only factors in a screening every other year as opposed to annual. And you see that generally speaking, we're only hitting about 50 to 60% adherence rate. We think a lot of that is resulted from access issues created by geography, including manufacturing and industrial job roles. So next to healthcare, manufacturing, industrial type jobs, shift work is the largest opportunity for employment in these areas. And so shift work in and of itself can make access challenging, typically lower income levels, more hours to be worked, and a challenging decision for a person to make in terms of, can I take the time off to go and pursue screening or preventative health care? Average income for the household run around $50,000. Poverty level exceeds 17% in all counties in our service area. And so we knew we needed to solve for that. The map on the far right illustrates just the Floyd service area. So there in the center is Floyd County, Rome, Georgia. And the little pink numbers represent the number of locations available to women to actually pursue mammography. And so you see we have 2 counties with no access, and we have 2 additional counties with only a single point of access. And so we felt that mobile was going to be a key way to solve for this. Next slide. So in 2008, when we opened our comprehensive screening and diagnostic breast program here at Floyd Medical Center, we included mobile mammography and put our first mobile coach on the road. And we had 4 key pillars that we targeted to create access. We partnered with manufacturing and industrial locations. So we knew if we could get into these plants and mills and get access to the women who needed the care, we could actually change our statistics and improve rates. So we take our mobile coach on site to lots of different plants and mill type locations, and we include very non-traditional operating hours. So shift work in, and again, 24 hours a day. Most places run 365 days a year. So we approach it in that regard as well. We want to offer mammography services, screening services to women while they're at work during their normal shift of work. She does not need to stay over. She does not need to come in early. She certainly does not need to come in on her day off. So even at our larger carpet mills, as an example, where we go in and we have 150 women to screen, we're going to be there around the clock for 36 hours. So that woman who's on that manufacturing line at 3 a.m., we're able to pull her off the line for 30 minutes, get her screening mammogram done, and we lobby for those companies to allow them to stay on the clock so that they're not missing pay, because we also know that that missed wage may be a decision point for her and a reason why she wouldn't choose to have her mammogram. We also partner very heavily with the school systems and colleges in our area. We lobby teachers and the other support staff in the schools. We reach out via the teachers, parents, and custodial grandparents to try to get them scheduled for mammography when the mobile coach is on site at a school location. And then we partner very closely with principals and school nurses, and they serve as our champions, and they help us with our outreach and help us encourage individual folks within the school community to sign up and make an appointment. We have deep relationships that we've worked to grow over the last 18 years with community champions, so church leaders, civic leaders, and we have a large presence of very active African-American sororities and fraternities in our area. They have very large groups. They meet regularly, and they are able to help us get access into a lot of special locations that we probably would not be invited to otherwise. Rural primary care and urgent care, again, given the geography, the large county sections of Georgia for both us and for Navicent down in Macon, we have a lot of rural primary care and urgent care locations. And so we also have routine monthly rotations that we use at those locations. So the physicians who have their practice in Taylorsville, Georgia, know that the first Tuesday of every month, they're going to have a mobile mammography coach there at their practice. And then our team at the breast center partners with their team, and we actually go in and look at all of the patients that are scheduled for primary care services next Tuesday when we're going to be on site. And we help that doctor identify all the patients that are already scheduled to be need a mammogram. And we get that order put in for that patient and ask that physician to help us capture that woman while she's there on site. Next slide. So impact, how does this work? How are we doing? In 2025, Georgia went from our single original mobile unit here at Floyd to 3 units. So we added a second unit at Floyd, and Navicent added one, their first unit down in Macon. And just for the Floyd unit alone, that second coach, we were able to add 37 new distinct locations of service in 2025. We screened over 5,500 women on the mobile units. Right at 4,000 of those were done on the 2 Floyd units. 451 of those were baseline, and they were not 40-year-old women. The average age for a baseline on our mobile coaches is 46, but we see many women in their 50s, some in their 60s, and we even had a very young lady in her early 70s receive her baseline mammogram last year on our mobile unit. About a third of these patients that are served are past due for annual screening, and we actually count that at 18 months. So we give them a few extra months to get in, but again, 1 in 3 are past due. And then we pair that with our larger operating model where we offer our screening mammography results to patients within 24 hours. They're contacted by a mammography technologist. Our BI-RAD 0 to diagnostic workup runs about 3 days. About 80% of women, though, are seen within 1 to 2 days. And then the diagnostic workup to core biopsy, we offer same-day biopsy for most patients. So our average time there runs from 0.5 to about 1.8 days. And so getting women in, getting them access, and then getting them a quick answer when they have an abnormality on that screening, we feel is a key part of our success. Thank you.
Wonderful. So again, as questions arise, please be putting them in the chat. What you've just heard from Amy is really one of the most innovative approaches to trying to increase mammography across a region. I know as I've shared this story with colleagues, have been incredibly impressed and really so impressed by the impact. So next, let's flip to advances in therapy. And one of the most significant impacts we've had over this past 15 to 20 years has really been the impact on immune therapy. We have two wonderful folks to address this, both John Richards, who has been our leader for medical oncology for Illinois, as well as been in the front lines of these advances in melanoma and in the clinical trials, and then David Soto Pantoja, who is one of our investigators in immunotherapy and trying to advance those further. John, thank you so much for joining us.
Thank you for having me, Dr. Mesa. I would say when you approached me and said, I'd like you to talk about how the research in immunotherapy improved cancer survivorship, and I thought that was a great challenge. And then the worst part was you said, and you got to get it done in 5 minutes. So I said, okay, we'll take that on. So first I'd say clinical. In terms of clinical trials, using immune checkpoint therapies has dramatically improved the survival of patients with multiple cancers, and I'm going to try to demonstrate that in just a very short period of time. Next slide. So immunotherapy really represents a true paradigm shift in the way we are treating cancer, from using drugs, chemotherapy that directly kill cancer cells, to altering the immune system to recognize and kill those cancer cells. The clinical trials using immune checkpoint inhibitors highlights the impact that clinical trials have had on cancer therapy and the lives of our patients. Next slide. This is a 30-year journey, and it began in 1996 when CTLA-4, an inhibitor of T cells, was identified by Dr. Jim Allison. And soon after that, a colleague, Dr. Honjo, in Japan, identified the PD-1 blockade. That was in the laboratory. And then, so before 2011, melanoma was a disease that was treated almost exclusively with chemotherapy, but occasionally with immunotherapy with moderate success. And we had transient responses, very occasional long-term benefits. In 2006, clinical trials with anti-CTLA-4 became the hot thing that Dr. Hallmeyer and I were involved in treating melanoma. And we first did studies looking at what dosing to use, and then finally high doses using in metastatic melanoma. And that resulted in 2011 with ipilimumab being the first checkpoint inhibitor approved for treating unresectable metastatic melanoma. And we recognized a huge shift in how our patients were doing. Soon after that, the anti-PD-1 antibodies, pembrolizumab and nivolumab, were approved for treating metastatic melanoma. And then combination therapies were approved shortly thereafter in 2015, with both ipilimumab and nivolumab being approved to treat melanoma. And that sent us into a tailspin in terms of how we could improve the lives of our patients. Next slide. I often tell people that before 2011, I reveled in the few patients that I could actually get into complete remission. Now I'm disappointed if any patient doesn't achieve that goal. Before 2011, 5-year survivals were about 5% with metastatic melanoma. In 2024, a 10-year survival exceeds 50% with these new therapies. And this is truly the impact of clinical research. And in my last slide, we've gone from melanoma to now 24 malignancies that these immunotherapies have been used in and have improved either survivorship or complete remission. And on the far right, the VA system looked at the impact of immunotherapy on multiple cancers and shown the life years gained by using immunotherapy in these many malignancies. And this is all from the impact of clinical research that's done in our system and will continue. And I think Dr. Soto will expand on our future there. Thank you.
Wonderful summary, John, as well as, having had you lived through each of these trials, the impact is undescribable for those of us that practice oncology pre and post the development of immunotherapy. I frequently use for individuals just to see that impact, the case of former President Carter, who with melanoma that had metastasized to the brain, would likely have passed away relatively soon after that was discovered. And I believe he was on one of the early trials, and that really led to, again, him eventually dying truly of natural causes almost at the age of 100. So what an extraordinary, genuine impact. So where does this go from here? So for that, we bring on Dr. Soto Pantoja, who is helping to also lead our transformational team in immunology, immunotherapy. David.
Good afternoon, everybody. Thank you so much for giving me the opportunity to talk to you about our challenges and the future of immunotherapy. Next slide, please. So as Dr. Richard mentioned, immunotherapy objective is to harness the ability of the immune system to attack cancer. And so while we amplify our immune response to treat cancer, we have seen remarkable responses. However, perennial issues in cancer therapy come with challenges such as therapeutic resistance, and that leads to cancer progression. But then we have come up with novel approaches such as CAR T therapy, T-cell engagers, that to overcome some of these issues aside from relying only on immune checkpoint therapies, as it was mentioned. There's also issues with immune-related toxicities that can cause patients to progress. And of course, as many of us, including myself, are looking for clues as biomarkers to predict response and overcome adverse events. Next slide, please. And so the next generation strategies that some of us are working on are novel immunotherapy combinations. Part of our faculty and researchers are working on personalized medicine approaches, as it's not a one-size-fits-all approach. We're looking for adopted cell therapies such as CAR Ts, CAR NKs, that can be harnessed from the individual, from the patient, and then given back so they can attack their own tumor. And of course, through different partnerships, as I mentioned, community engagement, cancer prevention and early intervention, and use immunotherapies also as preventive strategies to prevent recurrence in many cancers. Next slide. And so fortunately, we can a cadre of investigators from across the whole enterprise, partners at Virginia Tech that are part of our cancer center, working on immunomodulation strategies, and also clinicians such as Park at LCI are working on switchable NK9 engagers in partnership with the Institute of Regenerative Medicine, our own W-Force. We are developing new approaches for antigens specific immune T cells, so they can be then educated to attack the tumor patients. We also can with cellular engineering approaches of using CAR macrophages, like Dr. Watanabe was working on brain malignancies, and also on novel immunotherapy testing using novel preclinical models by investigators like Mark Klein. Next slide. And ultimately, from research from share we're doing in our lab, we are looking for biomarkers of immunotherapy response, particularly the metabolic space. And so what we're able to show is that mitochondria, which is beyond the powerhouse of the cell, can actually determine and predict patient response. And we have been able to actually define metabolic signatures at baseline that can predict therapeutic response, and they're correlated with the overall survival of patients. So this suggests that we can come up with metabolic targets and biomarkers that can predict and be used to treat immunotherapy response. So next. So thank you very much, and to the next.
Great. So again, as you have questions for both Dr. Richards and Dr. Soto Pantoja, please be putting them in the chat. So next, let's take a deeper dive into one specific cancer. It's an area that is a great area of focus across Advocate Health, from therapy to research to survivorship. It's an area that both the Cancer National Service Line as well as the Neuroscience Service Line are working on together. And with this, we both have Dr. Richard Rovin, who has been doing great research in terms of new therapies based in our Wisconsin division, and then Dr. Roy Stroud, who is a neuro-oncologist, also working on new therapies and clinical trials. Let's first start with Dr. Rovin.
Thank you, Dr. Mesa, and thanks to the organizers of this event, and greetings from Milwaukee. I'm pleased to share with you some of the work being done across the enterprise to find new and effective treatments for glioblastoma. Next slide. Glioblastoma is the most common primary brain cancer. It accounts for about 13,000 newly diagnosed patients each year. Glioblastoma carries a poor survival, 14-month median survival, and under 7% 5-year survival. And sadly, there are only 5 FDA-approved medical treatments for glioblastoma, and there have been no new approved medications in the last 20 years since the current standard of care was introduced. Next slide. So what we have seen is that there have been very limited clinical trial success. In the decade following the introduction of temozolomide, the current standard of care, there were 417 clinical trials, including 16 phase 3 trials for glioblastoma. About 32,000 patients were enrolled, and one of these trials was successful, leading to a FDA-approved treatment. And when we compare this to other cancers, in particular breast cancer, we can see a real dramatic disparity. This is a graph showing the change in 5-year survival rates over the last century. And you can see that there's been tremendous progress in breast cancer with about 92% 5-year survival rate now. And again, for glioblastoma, we're looking at just under 7% 5-year survival rate. Next slide. Well, why is this? And certainly there could be some methodological reasons in the clinical trials, but the principal reason that we've had such difficulty defeating glioblastoma is because of the blood-brain barrier. And the blood-brain barrier prevents the majority of chemotherapy, immunotherapies, CAR T and antibody therapies from reaching the brain tumor. Across the enterprise, there are exciting new research endeavors that are aimed at finding new and effective treatments. And I'll just go over a couple of them. It's been my great privilege to work with Dr. Yang at the Levine Cancer Institute. He's a computational biologist, and he is developing new AI models and machine learning algorithms to create antibody drug conjugates, as well as bispecific antibodies that are actually able to cross the blood-brain barrier through receptor-mediated mechanisms. At Wake Forest, our colleagues in neurosurgery, Dr. Tatter and his team, are working with focused ultrasound. Using focused ultrasound, the blood-brain barrier can be mechanically disrupted for up to several hours. And during that time, systemically administered therapies have the opportunity to cross the blood-brain barrier into the tumor. And the other exciting thing is that this technology, because it opens the blood-brain barrier, permits two-way travel. So antigens from the tumor, for example, can get into the bloodstream, and this allows for the discovery of diagnostic and prognostic biomarkers, as well as discovery of new treatment targets. And then here in the Midwest, we are working with Zika virus. Zika virus, it turns out, is an ideal oncolytic virus to treat glioblastoma. It naturally crosses the blood-brain barrier, and it targets glioblastoma cells through receptor-mediated mechanisms. So we are in the midst of our IND enabling experiments, and we hope to bring a clinical trial to our system in the very near future. Thank you.
Wonderful. Well, a very exciting example of innovation and trials, that will develop and originate from across the system, and hopefully then be a resource for patients across Advocate Health. So next, discussing some further approaches, how we're going to make an impact on these diseases. Dr. Stroud, that really wears many hats, but I know, as he has shared with me, the hat he values the most is really being a neuro-oncologist and really trying to tackle these diseases. So thank you for being here, Dr. Stroud.
Spot on, Ruben. So excited to be here with you and to be able to continue the conversation about CNS oncology that Dr. Rovin has introduced. And I'm excited to share a few slides about some of the really exciting work occurring in CNS oncology and specifically with brain metastasis from around our sites. Next slide. So I wanted to start by sharing some of the really exciting advanced technologies that are being leveraged from around the cancer centers, where many of our clinicians and clinician researchers are taking bold steps in the clinic today to advance the care for patients with brain tumors, both glioblastoma and brain metastasis. And I'll start at the top left. So this is an MRI image from a patient with a deep lesion. And Dr. Rovin introduced the blood-brain barrier being one challenge that we face in the brain. And the second are these deep lesions that are very difficult to access surgically. And so our teams across North Carolina have really pioneered the use of LIT, laser interstitial thermal therapy, so a thermal ablation approach to tackling these lesions. So instead of a patient coming in and having a large surgery with a difficult recovery afterwards, they come to the operating room and have a small burr hole placed, and you can see the laser probe in this patient accessing this deep lesion in the thalamus, and it's treated with thermally with an ablative approach that has become a highly effective strategy, a non-invasive method of evaluating these patients. And this has been pioneered by Steve Tatter, Adrian Laxton with our neurosurgical team in Winston-Salem, a clinical tool that they have expanded into our research portfolio and are now the top accruer evaluating LIT laser therapy for patients with brain metastasis that have undergone radiation therapy, where we don't know whether the tumor after radiation is progressing or perhaps changes on the MRI are a result of radiation treatment effects. And this allows us to both diagnose that finding with a biopsy and then therapeutically treat it. Moving to the bottom left of the slide is the first proton center within the health system, the second in the state, and one of only 47 proton centers around the nation. And this is changing the way that we're able to deliver radiation therapy, one of the backbones, the workhorses of therapies in CNS oncology to patients. Radiation therapy is arguably the most effective and important treatment we have. We want to open the blood-brain barrier, as you heard from Dr. Rovin, but radiation therapy is really the most effective way to treat these patients. And one of the things we worry about is cognitive toxicities or other effects of radiation to normal tissue. Proton therapy offers the ability to deliver that highly effective radiation dose without the risk of side effects and toxicities, and is changing the way we treat young patients and adolescent and young adults with cancer, and has been an exciting new technology piloted by Stuart Burry and Roshan Prabhu and the radiation oncology team in the Cancer Center. And then perhaps the newest kid on the block is on the top right of this slide, and you heard a little bit about focused ultrasound from Rich. This is what it looks like to the patient. And so this is our high and low intensity focused ultrasound machine. The patient comes in to the imaging center. Their head is placed in this water bath, and sound waves are used to either deliver a treatment, an ablative treatment to the brain, or to open the blood-brain barrier. And our neurosurgical team is just launched on the bottom right, the first trial looking at low intensity focused ultrasound to open the blood-brain barrier prior to chemotherapy treatment. And this is going to change the way that we think about treating CNS cancers in the future. So you can see in the green, patients come into the imaging center, they undergo low intensity focused ultrasound with delivery of these micro bubbles that help to open the blood-brain barrier. Then they go to the cancer center and receive their chemotherapy just like they normally would, changing the way that we deliver drugs. Next slide. At the same time, we're looking to develop new models in the lab. In the top right, we're looking at an AI model that is changing how we evaluate pathology slides for patient. Normally, our pathologists would select the most ideal slide to make a diagnosis for patient, and Yuming Zhang is using AI to evaluate and label each of the cells in those slides across all of the sections of the tissue to provide risk prediction for patients and help to characterize not just the tumor, but the microenvironment around the tumor as we evaluate and better diagnose patients. And then lastly, on the bottom right is an amino acid PET. FDG PET doesn't work so well in the brain. You can see the brain in the image on the left lights up as hot as the sun and doesn't allow us to resolve tumor tissue. And so our colleagues in radiology, Mark Benayoun and team, are piloting amino acid PET to differentiate tumor, you can see in the middle on the green, from radiation necrosis on the far right to help us to better understand how treatment evolves for patients. And the next slide, the last slide, is then improving care for patients. So we're looking at faster starts and better outcomes through a prehabilitation program, one of the first in the nation to start rehabilitation, not after the patient finishes therapy, but after surgery and before radiation and chemotherapy have even begun to improve functional recovery for patients. So Ruben, we'll turn it back over to you. Thanks for the chance to talk about some of these exciting things in CNS oncology.
Wonderful. Well, thank you so much, Roy. And in many ways, you helped to set up our last topic, which is really focused around patients' recovery and the concept of survivorship and integrative oncology. And with this, there's a tremendous amount of effort going on around our system. There's great passion, as I have the chance to really meet with many of you, on how we can better serve and care for our patients across their entire journey. And with this, we both have discovery science. So Dr. Alfonso Romero Sandoval is helping to lead our efforts in the science of cancer symptoms. And then Dr. Sandeep Chanduri is a very active clinician, investigator, clinical trialist, very passionate working with he and his colleagues there in Northwest Chicagoland of how we try to bring integrative oncology to our practice. But first, let's start with Dr. Romero Sandoval.
Thank you, Ruben. Could you hear me well?
Yes.
Perfect. Okay, so I want to begin celebrate research with a person, not a pathway. My aunt is a passionate educator in Guatemala, and she has spent her life opening doors for children in rural communities. But one day, her doctor told her she has developed aggressive breast cancer and that the treatment that may save her life could also leave her with chronic pain, numbness, and weakness. So next slide, please. So this is the reality of chemotherapy-induced peripheral neuropathy, or CIPN. It affects roughly 40 to 60% of patients receiving chemo, and it is not a minor side effect because it can become dose-limiting, it can force treatment reduction, and in some cases become irreversible. So patients can develop tingling, numbness, burning pain, and over time, even motor or autonomic dysfunction. And despite how common and serious CIPN is, we still do not have an effective way to prevent it or to treat it. So next animation, please. Thank you. So our lab proposes that the immune system is not just reacting to nerve injury, but leukocytes may actually help drive neurotoxicity through a particular pathway, the IRA1 XBP1 stress pathway. This is a signaling pathway that shapes immune function and has been linked to both pain and cancer. Next slide, please. This is where the story changes. So today, the usual sequence looks like this, like in the top panel. A patient starts chemotherapy with hope, the tumor responds, but then CIPN emerges. And suddenly the conversation shifts from how do we kill the cancer to how much toxicity can this person survive or endure. So that often leads to treatment reduction or interruption. And with that, for the patient comes fear. Fear of incomplete treatment, fear of recurrence, fear that survival itself may be compromised. So the real problem is not only pain or neuropathy. It is that toxicity forces a trade-off between treating the cancer and preserving function for our patients. That is the narrative we want to break. Our goal is to replace the reactive model that we have already with a precision medicine model. Instead of waiting for patients to develop neuropathy, we want to identify risk early. The idea is to combine a functional biomarker assay with IRE1 alpha pathway assessment. We expose immune cells from patients to paclitaxel. We test them and we assay whether they generate neurotoxic signals ex vivo and use that information to identify who may be at high risk of developing CIPN. Then, instead of simply reducing chemotherapy after chemotherapy-induced neuropathy has begun, we could intervene earlier and more intelligently, potentially pairing paclitaxel with an IRA1 inhibitor in the patients most likely to benefit. So this is a difference, we believe, between managing consequences and changing trajectory. So next slide. So ultimately, this work is about more than one molecule and more than one toxicity. It is about changing the experience of care in our cancer patients. The vision of this last slide is simple, I think. Identify the right patients, understand the biology, tailor the treatment, and protect quality of life. I think back to my aunt and to so many patients like her who hear that they must endure pain in order to survive. Our hope is that one day the message will be different, not just this treatment will fight your cancer, but also we can help you complete it with less pain, better function, and better life after cancer. Thank you.
Great. Thank you so much, Alfonso. So finally, let's talk a bit about integrative oncology and how this is coming to the clinic from one of our outstanding medical oncologists, as well as someone deeply involved in clinical research. Dr. Chinduri.
Thank you. So my talk's on integrative oncology, and integrative oncology is a patient-centered discipline that combines evidence-based complementary therapies with conventional cancer treatments to address the whole person, body, mind, spirit, symptom management, prevention, all the above. So why does this matter? Cancer symptoms drive utilization and quality outcomes. As a practicing oncologist, I think I spend more time dealing with the side effects of cancer, the side effects of chemotherapy, as opposed to, developing a treatment strategy. So that's one kind of strategic imperative. The second is there's gaps despite standard imaging. And three, genetics and prevention are the central to future oncology care. So what's the role of integrative health? It addresses symptoms not fully addressed by conventional care. It allows us to enable low burden research participation, and it bridges prevention, symptom management, and survivorship. So our goal is not to replace standard therapy, but to work alongside them to improve outcomes, quality of life, and tolerability. Next slide, please. So the first study that we're very passionate about and enrolled numerous patients is the iCare Research Registry, which is an inherited cancer research registry and prevention. So by participating, individuals help provide information useful describing the natural history of cancer development, the effects of surveillance, preventative interventions, and the impact of genetic counseling and testing process on those at risk for hereditary cancer. So it's system-wide, it connects patients, it focuses on the natural history, it improves screening, prevention, and family communication. One such example is in patients who have had a BRCA1 or BRCA2 mutation, and they've done studies looking at ovarian cancer risks, the effective age at first full-term birth on breast cancer risk in carriers, the risk of breast cancer in BRCA1 and 2 carriers without a first-degree relative. And they've also looked at the association of smoking as well as hormone replacement therapy after oophorectomy on breast cancer risk among BRCA1 carriers. So why is this important? It's scalable, it advances genetics-informed oncology, and it positions Advocate Health for population health impact. Next slide, please. The second study I want to talk about is this Astrin Bioscience looking at dense breast cancer screening innovation. It's a liquid biopsy using proteomics. It addresses reduced mammography sensitivity. As we know, mammography is not as sensitive for dense breasts. It's minimally invasive, it's patient-centered design. In one study looking at over 1,200 patients, this test achieved 92% sensitivity, 93% specificity across breast cancer stages and subtypes. It combines AI and proteomics, looking at 9,000 proteins to detect the earliest molecular markers of cancer, including in women with dense breast tissue, where I think, like I said, mammography is somewhat limited. So how does this help? It's early detection, like we want to see cancers detected at an earlier stage. It complements imaging and lifestyle-based prevention. And, I think this would be very, very easy to accrue to, because I think most women would sign up in a heartbeat. Next slide, please. The next study that's kind of fascinating is aspirin and cancer symptoms. So what this trial explores is the role of aspirin in cancer-related symptoms. As we know, aspirin does suppress platelets, which can decrease inflammation, decrease tumor growth, and it improves the immune system from removing cancer cells. There is effect on T-cell immunity. It affects immune modulation, cell metabolism, DNA repair, and it also reduces inflammatory reactions. Why is this integrative? It's low cost, widely accessible for everybody. It bridges conventional oncology and symptom science. There's high relevance to real world patients. So it's an easy study to accrue to, and we're kind of excited to participate in this. Next slide, please. And then my last slide is what's next? We want to focus on symptom-focused studies, expansion of registries and prevention studies. We also want to have multi-site accrual standardization. And why is this helpful for Advocate Health? It's a differentiated oncology care model. It's research ready. I mean, we're already research ready, integrative infrastructure, and it's strong positioning for NCI-aligned growth. That was my last slide. Thank you.
Wonderful. Well, thank you so much, Dr. Chunduri. Why don't we pull up the panel of our speakers? We have a a couple questions. I know we're almost at time, but we'll try to get through a couple of these and maybe extend by just a moment or two. So first, this is a question either for Dr. Rovin or Dr. Stroud. Is Advocate one of the only sites in the U.S. using the ultrasound technique you had mentioned for brain tumors?
Yes, there are only a handful of sites that are a part of these early trials looking at ultrasound for blood-brain barrier opening, and Advocate's really excited about this. I think we're really excited to have this technology. The trial literally just opened within the last month here, and so it's an exciting technique that's really only available in a small number of locations at this point in time.
Wonderful, wonderful. Next, perhaps I'll take on one of these questions. There's a question, what do you see as the biggest impediment to implementing trials across the enterprise? Funding, staffing, incentivizing investigators, sponsor engagement, etc. So one, I'd say that this is really a major goal for Advocate Health, both in cancer and non-cancer, with both the National Center for Clinical Trials as well as all of the efforts going on in cancer research. For those less familiar, we really have tremendous infrastructure with both the Aurora NCORE that had been through Illinois and Wisconsin really being a tremendous infrastructure for clinical trials, along with the Advocate Aurora Research Institute. There's really been one of the leading kind of multi-site system-based NCOREs in the United States. And then in North Carolina, there's been the NCI Comprehensive Cancer Center. And then in Georgia, there's a great tradition of clinical trials that's only going to grow. So I think that there's a lot of opportunities that we'll be really aiming to have key trials across the system, both investigator-initiated trials that may develop from any corner of our system. So again, if Amy comes up with a strategy for mobile mammography, how do we wrap around a trial around that? Or the agent that Dr. Rovin had mentioned. So again, many opportunities. So next, let me ask a question of Amy Griffin. So with your experience of how mobile mammography kind of expanded and the partnerships in Georgia, what do you think are some lessons that are applicable as we try to bring some of these experiences to the rest of the system, both urban and rural?
Yes, great question, Dr. Mesa. I had the privilege of spending some time last week, a couple of days in South Chicago with the Advocate Christ group, looking at some of their mammography programs there. And so very urban areas, but still a lot of those same challenges with access, right? And so I think the theme to me is, how do you figure out how to meet people exactly where they are and offer a screening service in a way that makes sense for them to access it? And so thinking about that Trinity Hospital location and some of the challenges that are probably unique to that community, again, where do we need to show up with mobile mammography, mobile CT? We're super excited. We're going to be adding a mobile lung coach here in Rome in a couple of months. And so I'm excited to see how we can take the mammography operating model and move it over into lung screening here in Northwest Georgia, but then how we might spread that throughout the enterprise.
Wonderful. A question for Dr. Stroud. What role do our innovation districts, the Pearl, the Innovation Corridor, and others, play both in the cancer research, but potentially in other areas?
Yeah, this is an interesting question. I'd love to know what some others on the panel think about this. I mean, I think my reaction is maybe three things. I think space and co-location is actually critically important these days. It's great to log on to the Cancer Center virtual connection, and yet a lot of what happens in research, as I think many may attest to, is the ability to really run into folks doing work. Alfonso mentioned the CIPN study, and I've been excited to collaborate with him on this, which happened over one of those kind of meeting connections. So having these spaces that bring clinical and basic and population researchers together, I think remains a really critical thing for cancer centers, for translational research. Biotech is what makes things go. And so having spaces where, biotech companies, spin-off companies, can be, and this has happened in the Innovation Corridor now for many years. And Dr. Mesa, as you may want to attest, this is happening in the Pearl now with new researchers bringing companies in that are collaborating with that kind of more typical academic home together in one place. And then maybe the third thing I'd say is, in those quarters are the students and the residents and the grad students and the postdocs. And so we saw a lot of research today, and that's often on the backs of individuals that are doing the work and learning the techniques and bringing those things forward. And that's also what lives in some of those districts and helps make research happen, certainly in cancer as well as other areas.
Wonderful. And then maybe a final question, and perhaps get input from both John and Sandeep. So both of you have been really involved with clinical trials and great accruers to clinical trials, both at Good Shepherd, at Lutheran General, and others. What do you think are some of the most key things as we try to grow our impact on trials to make them be as patient-friendly as possible? What are the key things that resonate with your patients when they choose to enroll on a trial where you've been practicing, as well as what do you think have been the things that people have brought up as barriers that lead them to choose not to participate in a trial? Maybe Sandeep first.
I don't mean to brag, but my success rate is pretty good. No, I'm kidding. To be honest with you, I think, patients always they understand that the only way oncology has advanced to where we are now is participating in clinical trials. And so I think most of the clinical trials we are offering are like cutting edge, like a lot of them with immunotherapy because everyone wants immunotherapy. So I think it's great when we have a wide variety of trials that include immunotherapy, but a lot of the other ones are, some supportive care ones where, we're looking at packaging of the CDK4/6 inhibitors. Those are easy ones to accrue to. So I think if, it's kind of how we sell the study and make it easy for the patient to understand that. I think it's really easy to enroll, to be honest with you.
Wonderful. John, additional thoughts?
I would totally agree with Sandeep's view that trials are easy to sell. It's really a question of making sure we have the support structure behind us so that, Dr. Chanduri and I don't have to spend an extra half an hour selling it to somebody when the next two patients are waiting for us. So I think providing that support is the key piece that the system needs to recognize.
Wonderful. And I'll share on a very positive note. So as a system, we're going to be rolling out Lind AI, which is a clinical trial matching AI platform of which we have been a collaborator through CancerX. Colleagues performed a study trying to demonstrate the value of this platform compared to some of our very best coordinators in terms of trial screening, and have had some very, very positive results that will be at a high profile ASH oral presentation or ASCO oral presentation coming up next month at ASCO. So you'll hear more about that. That is in final stages of hopefully acceptance of a high impact publication, as well as important highlighting of the efforts of Advocate Health at ASCO. So with that, let's go ahead and conclude. First, a huge thanks to all of our wonderful speakers. I hope folks that attended today really got a tremendous sense of both the breadth, the depth, the different themes of cancer research going on across our system and the impact that it's having. And two, hopefully come away excited at all of the amazing colleagues and potential collaborators they have really across our system. It's a special place. We have an opportunity to really make a tremendous impact. And with that, let's celebrate research and the impact that it has this whole month through this effort through the Wake Forest School of Medicine. Thank you, everyone.
Thank you.
Bye-bye.